to be in a panel or to speak on something is post-lunch, because most of your audience will be in drift mode. So, if you commit a blunder or make any wrong statements, you can escape because, audience will not be very attentive. So that's the challenge that we are having. So hopefully we'll try to keep you awake with some good discussions. And I have a fantastic panel today. And the topic that is given to us also is of very great interest due to multiple reasons. One, people think that state showcase, people feel that it's only public. It's not only public, it has the private side of it. So we will be discussing a lot of factors related to the public and private in the state showcase. So we all know last few years in the pandemic times, all the healthcare professionals were almost pushed to the edge of, the tolerance. And it also gave a lot of new perspectives and how to face new challenges, how to plan for the future, how to predict future, reinvent ourselves, how to, there was, I think, the design panel was saying jugaad work to adjust with the pandemic challenges. So I think Mr. Shiva is still sitting there. He used the word jugaad. So it's a very good word. So jugaad, we did a lot of jugaad. So that has created an environment where everyone has started thinking, okay, what will happen in the future? There's an uncertainty. We don't know what is going to happen. Okay, one pandemic came, we learned a lot of things, we experimented and then came out of it. But then future offers a lot of such uncertainties, which we are still, not aware of. But preparing ourselves to face any uncertainty is always a good thing. So we can see both private and public sectors in healthcare have done that. You can see our own state, Telangana, has allotted close to 3,000 crores to establish hospitals, which can support the affordability and accessibility to the public. And I read recently in a statement given by the Honorable Health Minister that Hyderabad has become the third in the country in terms of medical facilities, and also the first in terms of MBBS seats per population in the country. So state has invested heavily, and I'm told when during before the combined state nature, Telangana had only something like 1,200 oxygen beds. Now we are at about 30,000 oxygen beds. So that shows the preparedness that the state has done to prepare for any uncertainty in future. But taking all these steps, whether these investments or initiatives, plans, opportunities, whether this will help us to cope up with the future, whether taking such proactive steps will take us to the universal health coverage. So these are all points which will be discussed in the panel today. To discuss that and more, we have a fantastic panel already. Introductions have been given. So I'm really excited to moderate this panel. And so without much delay, I'll pose the first question to Mr. Pallab. He is a veteran in procurement. He is now heading Gleneagles Global India region, the entire procurement commercials. So Pallab, the whole thing is that we always talk about, we heard Professor Ramana Reddy also speaking about universal healthcare, the challenges, opportunities, and the solutions. But what do you think? Where is our state, Telangana state, leading in achieving the universal health coverage? What do you think are the real challenges and problems in our state? So we'll start with that and then take the discussion forward.
Thank you for the question. And first of all, I want to thank to the organizer for such a beautiful event. Across the industry, so many good and distinguished persons have come. Thanks for that. Now coming into the questions, this is very rightly pointed out that what the Telangana government should do to achieve that national health coverage. So wanted to give 2-3 figures. As per the WHO study, 80% of a person's total healthcare requirement throughout his lifetime can be availed from the primary healthcare centers. And at any point of time, like either today, tomorrow, whatever the total number of healthcare requirement across the persons throughout the globe or be it India, 90% can be covered through the primary healthcare system. What does this mean? That even if just we focus on the primary healthcare centers, like say whatever the PHCs and the UPHCs are there, will be almost win the match. That is what the focus is there, and that WHO study says. Now coming into the figure at the Telangana, there are total 867 primary healthcare centers, considering even the urban primary healthcare centers, and they have total 1072 of the revenue mandals. That means if we see that almost every revenue mandal has one primary healthcare center, that is definitely a good figure. But still, is it sufficient? We can say that there is no end of that. We should not be 100% content. We have to achieve more and aim for more. The reason being, more and more people, if they can be covered on that PHCs, and if the government budget is being such that people are also interested to go there, we can always get our that achievement. Just giving a figure, Telangana government has 12,261 crore budget allocation for the healthcare for 2023 and 24. Even if government just increase this by a few 0.5% of their overall allocation of the budget, then the entire rural population can be treated on the PHCs itself, because there are only 30 government hospitals in the Telangana, and most of the things are concentrated to the Hyderabad region. So if government can focus on building the more PHCs and UPHCs on the rural areas that consist of 66% of their population, then we are almost at the end of our winning the match. This is just a figure. But there are a few challenges. Why the people are not interested to visit in the PHCs? One of the few reasons will be those are ill-equipped. Ill-equipped doesn't mean the equipment is not there. But the thing is, whatever the facilities are there, we are not able to maintain properly. Many a time if you see, either the doctors are not there or the proper staffs are not there. And how we can do this? It is possible if we can incentivize to the doctors and the staffs. You know that in West Bengal, what government has done, that after passing the MBBS, minimum 2 or 3 years the doctor has to spend in the rural areas, then only they will get their confirmed license. So if that is one of the case, we're not saying that they have to give some stringent measure, but some way if we can, government does the incentivize to the staffs or the doctors, and they can monitor from across. All these 867 PICs are connected to CCTV. That means government can see, their DMHO or whoever is the government person, they can see from their offices that what is happening there. So this is 2-3 few tricks. Apart from that, few of the things government can utilize the budget properly. One is underutilization, another is overutilization. There is skilled staff is very scarce. Whoever the nurses or the technician or the pharmacist are there, inventory management is not good. What does it happen? If one of the, say, medicine, even if it is a lower cost or higher cost, if it has been wastage by way of expiry, that means you are losing the money. And simultaneously, wherever if you need any urgent requirement of the consumable, say simple needle or the syringe, but because of the bad inventory management, you are not able to have that stocks. Or say even simple betadine or say simple gauze, those things are not there. That means your inventory management is not proper and you are not treating the patient properly. So these are the few things we think even the Telangana government, even though I have to say, must have to say that Telangana government is one of the few of the state government which is doing very good. In fact, in the last 5-6 years, one of the pioneer, as Hyderabad is also becoming a hub, in tourism. What Dr. Anuradha has also said in the morning, that these are the few of the indicators that the government is really doing good, but we also should not be complacent. There are still something we can go, we can achieve more.
Thank you, Pallab. So the few, really good thought process that he has brought in. One is the budgetary allocation or the inventory management, the rural mandatory service, or the 66% of rural service. So one happy news for all of you. I don't know if you people would have gone through the news. Today there was an article that the CGHS rates are going to get revised. So which was a long pending request from our side. 2014 rates we still, I wanted to actually ask Madam, when government is doing so much towards the health, These are things, you want the best care to be given. At the same time, you want the hospitals to offer 2014 rates, 2014 tariff. So the good news is that announcement is going to come next month. They already have set up a committee which has almost closed the rate revision. So that's happy news for all the administrators anyway. So taking the point from where Pallab mentioned, I want to take it to Neeraj. Pallab mentioned more about the public health, right? So we know that universal health coverage cannot be attained just by strengthening the public sector. So private health also has an important role to play. So what do you think? So Neeraj is also a senior healthcare administrator. He is the commercial head for Rainbow, heading the pan-India procurement and their commercial functions. So you have seen the ups and downs of healthcare for so many years. So what do you think the private health can support, or what are the collaborative opportunities?
Yeah. So I'll start with this. We need to re-engineer our thoughts. I'll ask you a simple question. In the COVID time, 3 years or 2 years, whatever we have seen last, we have seen it's not the private have done fantastic. We are equipped. We delivered the best what is required, or the government have delivered what is required. We have seen many places, many cities, many states, they joined the hand and they could able to deliver a required care. There are multiple avenues where we should come together and think. If you ask me, there is something is required which will be a central depository. Central depository it may be a best practice, what a state government, a government doctor, because I feel for any outcome, any good healthcare outcome, I will be specific, what is required, more chunk of patient, more chunk of data, which proves which practice is giving you or yielding you a best result. Right now, we might be integrated with each other, but it's in the broken cells. We are not as a one, we have any kind of depository or a learning tool for a coming healthcare leaders. So if I know supply chain, I belong from supply chain, I have algorithm where I can see, I'll run algorithm, I'll see which material goes well, which material goes average, which material is not moving. Same way in the clinical outcome. If we have a good data, which is shared among all, maybe removing the patient part, it may be definitely a confidentiality part will be there. If the protocols which is followed in government and private can be shared with each other, it's not only private can help government, even government can help private. There's a kind of volume they treat, we treat only cream. They treat mass, where the good practice or proven practice can be seen. So here is I urge, if we can have a kind of data tool shared among a national level, which gives a learning to newcomers. That's it. Thank you.
Thank you, Neeraj. So I think ABHA card, which the Ayushman Bharat Health, the network card, which is going to be their health account, basically. So that I think will bring that into the complete picture, because ABHA card is supposed to, have the data transfer seamlessly between private or public. So you have touched upon the usage of data and, probably the good practices between public and private. So that takes me to Saurabh, a very interesting perspective. What do you think, are the private-public partnership opportunities in, achieving these goals? Do you think any such examples are there in Telangana, or from your experiences that you had in the past, any such experience you can share? Saurabh again is a healthcare leader who has worked with Fortis, now he's with KIMS. He's also having a very strong consulting background, so I think he's the best person to answer this.
Thank you, Devanand, for your kind words. I'm still a student, so I learn new things every day. And thank you, ET Business Consulting. Actually, I've been part of the Healthcare Summit, I think from the first summit, which was in 2020 when we were struggling with pandemic. So regarding the PPPs, it is actually it's a very pertinent question. But let's look at the background of PPPs. Is this better?
Yeah, I think.
Okay. So when you talk about public-private partnerships, the response throughout the world has been lukewarm. Less than 7% of the PPPs across the industries are in healthcare. PPPs are actually very successful in infrastructure projects, energy, education, and some of the other facets. Healthcare has been lukewarm. There are some successes also. And my push is that Telangana actually, as Pallav has already pointed out, is one of the best performing states when it comes to healthcare. So it should not only learn from others, it should set examples for others to follow. Not only in India, but in Southeast Asia. So Telangana, as of now, of course, Pallav and my other panelists have told you the data points, but over 99% of the deliveries in Telangana are institutional. That's a big thing. The infant mortality rate, maternal mortality rate, since the creation of the state, it is a new state, have halved. There are schemes like Kanti Velugu, which is the free screening of the eye ailments. It is the largest scheme in the world, ophthalmology scheme. It has already covered almost 3.8 crore people. These are some of the very good examples which Telangana has. Now, what is required is, see, in healthcare, whether we talk about 2% spend, 5% spend, or America's 16+% spend, it will always be scarce. The resources will always be limited as compared to other sectors. And the answer is not to actually increase the allocation. The answer is to join hands with both public and private should join hands. And actually what has happened after COVID, the impetus has actually come in this PPP model because everybody realized, including the government and the private sector, that there is nothing like private healthcare and public healthcare. It is one healthcare system. And if we need to, fight such pandemics and really go towards universal healthcare, we need to work as one. So that was a big impetus for, the PPP projects. And some of the projects have already started rolling in India. Now, when it comes to Telangana, they are doing excellent stuff. The only thing is they need to include more private participation because what is happening they are making 3,000 bedded these things, hospitals. They are also multiplying the number of MBBS seats and putting new medical and nursing colleges. Now, which is good, but what some of the other states have done, like UP, MP, and Tamil Nadu, they have tied up with the private players and given their district hospitals, their teaching hospitals, and they can actually build a hospital nearby that. So that has actually resulted in lots of cost saving, speedier delivery. So this is one example they can follow. The other thing, what is the need of the hour is actually to look beyond, to foresee what's the future. See, a city like Hyderabad, traffic is a problem. And in India, can anybody tell which is the largest killer in India? Anyone? This is very easy. More people die because of this.
And
yeah, exactly. So the maximum number of fatalities happen because of road traffic accidents. And that is because we don't have proper emergency medical systems in place. there are a lot of alternatives available. So you have 108, then you have, even private providers like Red Health, which are now claiming to have this ambulance in 8 minutes. But whatever said and done, in the entire country, there has not been even a single example of chopper ambulance or helicopter ambulance. Now that is need of the hour, because if cities are growing, and Hyderabad can actually set example to have a PPP model where they have helicopter ambulance and save precious lives. So this is just food for thought, because that is what is the need of the hour, setting, innovative things, going out of the, box. The second thing is to reach the peripheral areas, we are still relying on road transportation. Nowadays, drone delivery is something which is already established. Some of the, AIMS institutions and other institutes are trying for that, trying to deliver, even blood products and medicines. Now, to maintain this fleet of drone is actually quite cumbersome, because what happens is you will buy heavy capex items, and the serviceability and, the technical know-how of operating that might not be there, or it might get into government bureaucracy. The second area could be they can tie up with private providers and health. Hyderabad is not only the hub of medical, pharmaceutical and other things, it is also becoming an aerospace hub. There are a lot of companies which are coming into drone manufacturing. So they can tie up with someone, and then they can serve the masses which are in rural areas, and they can multiply what they're already doing good. It can actually be done in an excellent way. So these are my thoughts.
Thank you, Saurabh. Thank you, Saurabh. That's very, very good suggestions. The chopper, the drone, as well as private hospitals being set up, or private players setting up hospitals near the general hospitals. Drone, just to give an example, Aster as a company, I represent Aster. We have tried that. We have a few units in Kerala, and unit to unit, some tests and all samples we have to transport fast. We have experimented with the drone. Probably we are not completely operationalized the drone deliveries, but we have already made a beginning to the drones. So time is not so far when the medicine will come in a drone to your home. That is very much possible. The home delivery will be done through drone. Probably Zomato or Swiggy will bring your food also through a drone. That is very much possible in future. Okay, so since there's a positive time, I'm just taking the next question to Pallab. Pallab, see, when we talk about the government support, the government initiatives, the government's proactive measures, all those things, there are certain other things that come to our mind in terms of certain controls. So one such control, especially we saw the shortage of oxygen. So there is a circular which has come that every hospital above 100 beds should have a oxygen generator installed at their place. So this is the Telangana state notification, and we have a lot of hospitals in that category who will not have sufficient space to install such a generator. So going forward, people can play with the statutory order, and there can be some kind of issue for the hospitals. So how do you feel that such challenges can be overcome, or any specific suggestions from your side?
If we just see what is the origin of this government circular, hope you all can remember that at the time of COVID second wave, around March of 2021, the average oxygen consumption, medical oxygen consumption in the hospital was 1300 metric ton per day. And when the COVID-2 was at the peak, at the May 2021, that has increased to 10,500 metric ton per day. So almost 10 times of the consumption increase. So definitely it is not possible by any of the industries to cover up that gap. So you have seen that there is a long queues outside the oxygen plant, so that the patient's relatives were there with taking the empty cylinder to fill up when their number in the queue will be coming. And hope you have also seen that from industrial hub of Chhattisgarh or even Maharashtra, the trains were run to reach the far-flung areas at Rajasthan or Himachal Pradesh just to supply the oxygen. So by seeing all these things, the government has come up with this idea, And Telangana government, we have to appreciate that they have taken that leadership, that they have given this instruction that all the hospitals who are more than 100 beds, they have to install the oxygen plant. So as a way, this is a good step, positive step by looking at the future. That because see, we don't know that whether COVID-4, COVID-5 will be coming or not, but this is the preparedness. What is the pushing the government to doing this, and definitely it's a very positive thing we have to appreciate. But yes, few concerns are there from the private players that the establishment cost, I mean capex, they have to spend minimum of 50 lakhs. I mean it has started from that much of the amount depending on the size and the capacity of the oxygen plant. So that will be the minimum cost they have to spend. For the government hospital, okay, government has the sufficient budget, they can utilize that. But for the private players, that is an additional burden to them. Secondly, they are all either in the rented place or they have already designated their structure there. Now this oxygen plant, they have to keep a very separate space. They have to arrange that. Moreover, it is not only the utilizing the plant, but they have to have the safety, because being the oxygen, it is highly flammable. So they have to have the security arrangements. And if you see that after the COVID third, now the actual requirement has come down substantially. We don't need this much. Where the patients will require this oxygen, only of the person is the ICU, and that too who need the oxygen only, who are in the serious cases. So for that, there is an underutilization, fully underutilization of this oxygen plant. Moreover, most of these plants are PSA. It's not the industrially developed oxygen. It is a PSA plant where the purity is hardly 92 to 93%, which can be used only for the medium patient. But who have the breathing problem, who are in the serious case, they are in the 99% purity, which doesn't come from the PSA plants, which have to be taken from the industrially generated that liquid medical oxygen. But few of the things we can do. I mean, government can give the circular, like in any of the vicinity of this hospital who have installed that PSA plant, they can connect with the local other hospitals who have the capacity of less than 100 beds, because they do not have the PSA plant. They ultimately have to purchase the oxygen from the other industrially, whoever they're preparing the oxygen, or from this plant. So they can e-connect between themselves. And these are the few things we think, even though the intention of the government is good, but few steps we still can coordinate, making a robust system and the very sufficient information sharing, so that this oxygen, whatever is the excess capacity, that can be utilized, so that it is a win-win for both. The lower among hospitals, less than 100 bed, though no need to purchase from the far areas where industrially oxygens are developed, they just connect with the local hospital who have installed this oxygen plant. They can get it from here. And this hospital who is producing, they can also get benefited from it.
Thank you, Pallab. Thank you so much for the suggestion. Always should actually look at via media on how to settle that. So probably, the government can probably listen to the suggestions that you have made, probably have a modification of the circular. That will be a great welcome step. So, Neeraj, I just wanted to talk, because CEO, since you are also, representing the inventory side of it, because Pallab, when he made the response to the first question, he was saying that, in public, obviously the public sector always have that accountability on the budgeting, on the inventory management also. There is always that lack of accountability there. So what do you think, are there any specific learnings that we can take from the private to the public, which can be, or both sides, public also will be having a lot of good initiatives in the inventory management. So do you think any such initiatives that you want to, from your experience, you want to share?
There's a lot of technology or digitalization is making part of our routine now. If you ask me 5 years before, when I have gone to my CIO and I asked as a layman a question, sir, when by dispensing some medication to a patient in the same building, if we have 600 patients, there will be at least 600 into 3 indents, and each indent there will be 7 to 10 clicks. Is it required? So moment we ask the question, so first we have to evaluate your daily routine. You need to see if a medication is dispensed to a patient, how many steps is involved. If you go that level, if one indent comes, how many clicks? After generating a print, how many steps to bring the medication? If you go that micro level, then you generate a improved or the better robust process. Right now, there are multiple new technologies helping us. I'll give you a couple of examples which we implemented. One is the RPA, robotic process automation, which we implemented. My 19 processes are on RPA. So any repetitive task which we are repeating every day, we can turn to a RPA tool. My vendor reminders, whenever I am giving any reminders to vendor for the delayed delivery or maybe some wrong delivery, my robo will run in night and send morning one mail as a reminder, last 7 days so and delivery you failed to deliver on time. Then my dashboards, my alerts, my stockouts and my deviation. So if I have to do any controlled kind of mechanism, when you have a multi-unit setup, I have 17 units. Sitting in a corporate place, you cannot control 17 units. You need to have some technology support where you have at least key outcomes on your table, then you take a decision. So what we started moving, my each price deviation, my each product deviation from the recommended formulary or recommended drugs will land to my desktop every day morning. Which unit have done what percentage of compliance, what percentage of deviation, which helped me to improve my resource performance, reduce cost, and give me on-time delivery, on-time service to my patients. Yeah, that's it. Thank you.
Thank you, Neeraj. That's very interesting. So is this
So there are multiple systems available in the market. One is automation anywhere. Second is the UI path. So we have taken a UI path where there will be a bot, which will be a unattended bot. If it is unattended bot, there will be auto triggering based on a time setup.
okay? Yeah, thank you so much. So I think many of the administrators also can look at it. This is something which many hospitals have the similar challenges in terms of the reorder levels and the reminders to the vendors and the stockouts issues. So one point on the inventory side that Neeraj mentioned, but the other side is the accountability side. So Saurabh, so I just want, because you come from the core operation side. So always there is a allegation or a challenge being posed on the public sector that there is no accountability or quality to public. They really cater to the mass, even though there are a lot of new changes which has happened. Even now there is no solid accountability or quality that has come into the public healthcare system. That is why people still rely on the private healthcare, and the constitution of healthcare, if you look at it also, private is more. So what do you think, how can this be brought into the public healthcare system?
Okay, it's a very tricky question. So I do not actually agree that public healthcare is not accountable. The difference is of the perception and the yardstick which we use. So the expectation of a normal person is that if he's going to a district hospital, the district hospital should be as swanky as a Apollo or KIMS or Max. But is that required? Because when we talk about quality and service standards, quality is nothing but fitment for use. Now, as I was speaking in my last discussion on another question, the resources are scarce, and there will always be a challenge to serve the huge population. Now, do public hospitals actually fit in that criteria that whatever they are doing is fit for the use? So up to a large level, yes, there have been challenges in the past, but what is happening is, due to the onset of digitization, even in the district hospitals, and more importantly, IPHS standards, because previously it was like NABH standards are applicable for the public hospitals or not. So some of those standards make sense. Some of their standards are far-fetched because, they again are catering to the masses. But with the advent of the IPHS standard and with the mandate that majority of the hospitals are already IPH certified and the balance will be going for it, I think we can be rest assured of the accountability part. That's one. The second thing is, when we talk about accountability, we should not forget that public healthcare system has actually been tested in the first wave when no private hospital was treating COVID patients. It was the public healthcare system. I come from private, but I actually salute those doctors, nurses and healthcare workers. They were the first to start treating the COVID patients. And more importantly, with the advent of National Health ID and digitization now, I was reading an article 3-4 days back that over 60% of the district hospitals have this QR code based registration, and all the details will already be captured. Some of that will come through from National Healthcare ID and some of that can be keyed in the smartphone. I think the picture will be much more clear. Also, it's not on a lighter side actually. See, when it comes to accountability, nobody stops a patient or an organization to go to the court of law. So they are as accountable as any private hospitals. They can actually be pulled in any court of law. There is no provision which actually saves them. So I think they are accountable. Of course, it was ambiguous. It is improving with the time, with the digitization. And the future will see a very different sort of public healthcare system. That is for sure. Because healthcare in the current phase is changing. In the next 5 years, healthcare will not be delivered in the same way as it is being done now.
Thank you, Saurabh. So, we all know that public has done a wonderful job, but the accountability perspective, some people still feel that private gives a personalized care while public doesn't offer that. It is basically the mass that, or the kind of crowd that the public handles. Most of the units are choked. So thank you so much for your insights. So I think we have, almost coming to the end. Probably we will close with 2 more queries. So first one is to Pallab. So see now, in the opening remark, I only mentioned, and even Saurabh also mentioned that, Telangana government now is planning to invest close to 3,000 crores to set up hospitals. But after COVID, when you look at the exact healthcare sector, what is happening, there are a lot of hospitals in private sector which are closing down. Because, many people are not able to run it. People who have closed shops during the COVID time have not still regained the normalized situation. They are still struggling to run these. So when such a large number of beds are available in the state, in the private sector, and any hospital, if you look at it, any big hospital also, they may have infra to claim that we have so many beds. But are all these beds occupied? No. So we have already unutilized capacity in the state. So is there a need of, or do you think, will there be any sharing of beds between public and private, so that the unused capacity can be utilized?
This is also very good. This is also a very good question and a very practical question. One word which is in this phenomena we can say, that is interoperability. It has been conceptualized in US 2016 when Obama was there in his last year of the presidencies. At that time, US has conceptualized that let's have all this patient information as a data, be it either in the PDF form or be it in the Excel form, to store in such a way that that will help us in future. And when they have started this journey in 2019, this interoperability concept has been started in the US. It is the same concept of what the question you have asked. Then they have thought and they have realized if there is any unutilized beds are there in one hospital, or one hospital probably has one type of specialty, but when patient need any further assistance, that hospital do not have that much of specialty or that much of infrastructure. What will they do? Then this concept has come, if both the hospital can partner along with both of them, be it private to private, be it public to public, be it private to public or public to private, either way, so that it can help both. Few of the advantages there. Suppose if one patient has been admitted, say, in one hospital from where one of the specialties, suppose he has admitted for, say, cardiology, but after cardiology treatment, he has to go for, say, gastro. Now, if that hospital do not have the facilities of gastro, then he needs to first get discharged, clear all the bills, and then again he has to do a readmission of another hospital where the gastro treatment is available. Now, this is a very hassle for the patient and patient's relatives. They have to clear all the formalities of the discharge, all the formalities of the admission also in the second hospital. But if both the hospitals are intercompatible and they are interoperable and they have good collaboration, then it is just a click of mouse. It is just switch in and switch off. The discharge process can be closed immediately and it will be a seamless admission process in the next hospital. But few of the challenges are there which we have to keep in mind. That is, both the software have to be same. If the software platform is not the same, then the data available from one software, it cannot be populated to the another software. So all the patient record cannot be interchanged. And second, it has to be very secure of the data. Because as you know that in the morning session also people can point it out that we have also understood that in the AIIMS, being in the AIIMS, the premier hospital, still their server has been hacked, and that too for 2 weeks. That means the IT security should be very strong and robust enough so that there is no breach of the personal data of the patient. And in one hospital, suppose one set of doctors, if both the hospital do not collaborate properly, then the vocabulary or the proper procedure name, nomenclature might not be the same of the another hospital. So whatever the investigation they have mentioned here about the patient's health records and other thing, another hospital might not be knowing. So all these things also have to be kept in mind that both the hospitals should have the same same software as well as the same infrastructure and same supplier base so that it can be easily available. And this is a few things I think it is possible. Good thing.
Thank you,
but
Pallab. Yeah, thank you. I think the interoperability is something which both the sectors, public and private, has to really seriously look into, so at least to utilize the unutilized capacity in the other hospitals. So I'll take probably the last question to Saurabh. Dheeraj, excuse me, because there is only that much time left. Probably we'll wait for some questions also from audience. The same question I want to ask. Say, for example, now we mentioned that 3,000 crores is allotted by Telangana government. And we say that public is giving free. Is it really free? A greenfield project by spending 3,000 crores is never free. It is taxpayers' money, right? So with the real estate cost going high, the procurement cost going high, construction cost going high, the operations cost going high, really does it justify to have greenfield hospitals in public rather than this interoperable model? What do you think?
Okay. So let me throw 2 data points. So in 2019, there was a FICCI study. I was fortunately part of that. And that was the time when Ayushman Bharat was in its primary stages and government wanted all the corporate hospitals to do Ayushman Bharat. Now, we did an extensive analysis and we also involved AIIMS in that study. Guess what? The cost of a surgery in AIIMS is 2.5x than any corporate hospitals. And there are so many things which get added, which is the salary of the professors, the cost of infrastructure and the other facilities. So it was actually thought-provoking whether it makes sense. I will just leave it that. The other thing is there is another study which says that government spends almost 1.2 CR per MBBS student in AIIMS, which is not visible, so nothing is free. Somebody is paying, taxpayer is paying. The question is, what is the best use of that money? Coming to the new hospitals in Telangana, of course, hospital beds are required, but somehow I disagree on the proposition of creating new hospitals when you already have one of the highest bed to population ratios in the country. I think it is highest, followed only by Gurgaon in India. So when we already have so many hospitals closing down, so many hospital beds available, it is prudent that government goes into a PPP model and be a peer, rather be an operator of the hospital beds, because that will bring in more efficiencies. And I've already quoted 2 studies. There are multiple studies. So it might not be the best use of resources, especially when you have a huge population to serve, and majority of the specialists are still available with the private sector. So those are my thoughts.
Thank you so much for that food for thought. So I'll just take 1.5 minutes. I just wanted to ask just a rapid question to all the panelists. How many years do we think when the Telangana state will achieve the universal health coverage? Just probably take 10-15 seconds.
Yeah, it will be all my personal opinion, but seeing the progress at the Telangana government in the last 5-6 years, I guess within next 3 to 5 years they can achieve that.
Okay. Neeraj, what do you think?
I think we need to, it's not only infrastructure, the even mindset of people also need to be training. So it will take at least 5 to 6 years.
5 to 6 years. And Saurabh, anything? Yeah.
So it can be within the next 5 years, and it will be one of the first states. The only thing is it needs private participation. Government cannot do everything on its own. Of course, there are schemes like Kanti, Vilgu, KCR kits and all, but when you want to reach to the masses, you need to involve private. The example I quote is Chiranjeevi scheme in Rajasthan, which is hailed as the first universal healthcare scheme, but the caveat it only covers the population below a certain threshold. Now, when you talk about universal health coverage, everyone, irrespective of the monetary benefits or the affordability, must get the basic minimum healthcare. That's what universal healthcare. It is not only providing to people who are under BPL or a certain segment of people.
Thank you guys. So just I'll end with a closing remark from my side, and then any questions from the audience we'll take. One of my friends is in Manipur. Actually, he's a traveler. So he went to a remote village in Manipur, and he called me up and said that it's a pathetic situation here. A child in a family had fever for 3 days, and this mother has to take him 300 kilometers, travel close to 4 hours to see a doctor. So that's the situation in some parts of the country even now. We talk about e-Sanjeevani, we talk about digital. Yes, India is a big country. Yes, reaching the masses is difficult, but there is a huge scope. There is still that lack of healthcare support in many remote areas in the country even now. So telehealth or whatever mode, we have to reach all these places, and then public and private has a long way to go in going hand in hand in achieving this goal. Thank you so much, gentlemen. Thank you so much for your insights. We are open for any questions from the audience. Yeah. Can somebody give a mic, please?